Hello, welcome to Memphis virtually. We are excited to have this panel discussion with you on genitourinary malignancies. We are here, we have quite a large crowd today. Actually, thanks to the virtual platform, it enables us to expand our reach way beyond. And we are I'm going to introduce, I'll have everybody go around, we'll go around and introduce the panelists, and then we'll engage in a case-based discussion that I think you'll find very interesting. So I am going to, let's go around over here and everybody introduce themselves. Dan, why don't you start?
Hello, I'm Dan Vaena, medical oncologist here at the West Kansas Center. I run our GU program. I'm also the director for our phase 1 program.
Holger?
I'm Holger Gieschen. I'm a radiation oncologist at the West Cancer Center, and I'm specializing in GU and lung malignancies.
Jeannie?
Hi, I'm Jeannie Hoffman-Censits. I'm a medical oncologist at Johns Hopkins. I specialize in locally advanced and metastatic urothelial cancer.
Okay, Heather?
Hi, I'm Heather Greene. I'm a nurse practitioner at West Cancer Center. I work with Dr. Summer, mainly seeing GI and GU malignancies.
Okay, and Amy?
Hi, I'm Amy Luckenbaug. I'm a urologic oncologist here at Vanderbilt, specializing in all of urologic oncology, but mainly see bladder and kidney malignancies.
Okay, wonderful. Thank you, everybody. And thanks to our speakers and panelists and for your wonderful earlier talks that were really great and well received. Okay, we're going to go through some cases and then I'm going to ask some questions and try to facilitate an interesting discussion. So the first case we'll discuss is a bladder cancer case. So it's a 62-year-old male smoker who presents with 3 weeks of gross hematuria. He went to urology and there were multifocal non-obstructing fungating masses in multiple sites in the mucosa of the bladder. He had a complete TURBT and he was found to have high-grade TA non-muscle invasive urothelial carcinoma. He is a smoker. He has no other medical issues. Amy, how do you approach this kind of thing? What would you do?
So first, I would make sure the pathologist, wherever we were, had reviewed the pathology and agreed there was muscle in the specimen and it was negative. And then for this patient, I would think about where he would fall into risk stratification, and he has high-grade TA, and so he'd kind of fall in the intermediate risk category in terms of recurrence. So I would recommend that he do induction BCG, and if he has no evidence of recurrence after that, I'd recommend 12 months of maintenance BCG.
Okay, and then so walk us through a little bit about risk stratification here, low risk, intermediate risk, high risk here.
Absolutely. So those are AUA categories because there is a broad spectrum of how people do with non-muscle invasive bladder cancer. Low risk patients tend to be those who have low grade TA disease, a small lesion less than 3 centimeters. Intermediate risk patients are people with high volume low grade TA or high grade TA that is still under 3 centimeters. And those with high risk disease, this was in my presentation, so you can look at the slide, there's a nice table, but those with high risk disease are those with CIS, T1 disease, anybody with any variant histology, lymphovascular invasion, and people would fall into the high risk category. And those are people, in addition to induction BCG, if it works, we would do 3 years of maintenance as opposed to 1.
Perfect. And then what have you guys done with the BCG shortage that comes and goes? How do you approach that?
We've been fortunate in that we haven't lost it completely at any point, but when we were short, we always tried to put induction courses kind of to the forefront and always tried to do induction BCG for our patients. And then if we had enough, we favored doing maintenance in patients who had the high risk category disease. The other thing that we had done when it was at its shortest was we split doses and reduced doses and gave people either third or half strength BCG for their maintenance if it came down to that.
Right. So this person got intravesical BCG and followed surveillance cystoscopy, and 12 months later presented with recurrent bladder tumor, which was resected and found to be non-muscle invasive with CIS, was completely resected. Again, let's assume muscularis was present and not invading. Imaging was negative. So what's the chances of recurrence? What about muscle invasive? What's this risk category here?
So I think that's a great point, is that each resection you reassess the patient's risk categories. So he moves up now to high risk, the high risk category, because he has carcinoma in situ. For people with high risk, high grade disease, these people have, CIS specifically has about a 50% chance of progression. T1 disease has about up to a 70% chance of progression, which is high. 30% chance of progression, which to muscle invasive disease, and a 70% chance of recurring, which is quite high. So in this patient, you know, I would reassess, he's a high risk category. The risk of recurring is about 50 to 70%. The risk of progressing is 30%. And I tell patients 1/3 of you will progress to muscle invasive disease.
And Amy or Jeannie, can you tell us the difference between BCG refractory, BCG non-responsive? Tell us the difference. Is it difference if this was 3 months, 6 months, 12 months? What difference does that make? I think you're both on mute.
Amy, do you want to take the lead on that, since this
Yeah.
is oncology wheelhouse?
Yeah, absolutely. I wasn't sure if you wanted, absolutely. So for patients, you know, this patient, I actually would consider him he's not yet unresponsive, because he hasn't had 2 induction courses of BCG or BCG plus 3 months of maintenance. However, I'm a little concerned that he's BCG refractory, because he progressed on after BCG instead of staying either high grade TA or became low grade. And so I would talk to him about the possibility of doing repeat induction BCG, but I quote patients that's about a 20% chance of success. So alternatively, there are other agents you could do in combination, either gemcitabine and docetaxel. Some people could do gemcitabine alone, not quite as successful in CIS or high grade disease.
Okay, and what would tip you toward a cystectomy in this patient, or when would you go to cystectomy?
Yeah, in this patient, I think so far I wouldn't necessarily push him that way. I totally understand the need and desire to preserve your bladder. But if he had recurrent CIS after this next course, I might talk to him about that. If he had high volume T1 disease that wasn't able to be resected, or if he had any variant histology, micropapillary sarcomatoid, plasmacytoid, all of those are very bad players, and I would try to guide him towards upfront cystectomy. Again, saying that 1/3 of these patients do become muscle invasive.
And if they refuse cystectomy, what would you do in that scenario?
I would, great question. I would either go ahead and try all of the lines of therapy that we have after BCG. So I would proceed with either gemcitabine, docetaxel. If that failed, I would move them on to the pembrolizumab tract. And if that failed, I would talk about trials.
Do you feel that the gem docetaxel data is more compelling than pembro, or pembro more compelling than gem docetaxel intravesical?
I think it's kind of a toss-up. And when I counsel patients, I talk to them about both options and offer them the opportunity to go to MedOnc to talk to them. A lot of patients end up saying, I'd rather have something in my bladder first and do systemic therapy second. But maybe that's because I'm the one talking to them. And so I do offer them the chance to see medical oncology. Okay,
and then what trials do you have available that are exciting? Or Jeannie, do you guys have any trials in that setting too, failing, let's say they still don't want a cystectomy or have a muscle invasive disease?
We have a BCG unresponsive trial right now that is looking at, it's called the Altor trial. It's looking at BCG plus an interleukin intravesically. Everyone is getting the treatment. we've had pretty favorable responses, not obviously published yet. And then we are opening up another trial, which is going to be the TARIS trial. It's a pretzel you put into the bladder, and then it distributes gemcitabine over time. And that is going to be immunotherapy versus this pretzel versus immunotherapy plus the pretzel itself. So those are all good options as well.
Not the usual place I would put a pretzel, but that's okay.
Interestingly, we have used bladder preservation with chemoradiotherapy for muscle-invasive bladder cancer for a number of years, and it's one of the options. And of course, one would think if it works for muscle-invasive disease, why wouldn't it work for non-muscle invasive disease? Surprisingly, there's actually not that much data there, but there is actually a trial that RTOG 0926 did a trial for T1 disease that actually explored that option. This trial accrued and closed to accrual in 2019. So we won't know the answer for that for a while, but this is maybe an option that we can look into in the future too.
Brad, can I ask Amy a question that I think it's a challenging question? So a patient like this, Amy, that relapses non-muscle invasive and has CIS at relapse, and then let's say the patient starts Pembro, and the endpoint on Keynote 57 was a CR rate, as you know, but let's say the patient starts Pembro and 6 months later still has CIS. So when do you call, which technically in the trial would have been called a failure, but I see a lot of urologists are hesitant to take a patient like this to cystectomy because technically they haven't progressed, even though they really haven't responded to Pembro. When do you pull the trigger and say, okay, your CIS persists and it's time for cystectomy as opposed to keep doing Pembro for 2 years? How do you make that decision?
Yeah, that's a great question. I think there's some patient factors. If they are resistant, then I can see why people continue for 2 years. But I would strongly, and I have a few of these, encourage them to go ahead and proceed with cystectomy rather than just continuing Pembro indefinitely. I think at the 6 month, 3 month point, I reassess, and if it's positive, I give them another 3 months to see if they've responded. Again, there's I don't think evidence behind giving them another 3 months, but I try to give it a chance. And if at 6 months it still persisted, I would strongly guide them towards cystectomy. And if they refused, I'd send them back to you guys.
Great question. Okay, so thank you. Then moving on, we'll get, so this patient got intravesical gemdocetaxel and then presented with recurrent pumicating mass in his bladder with T2 disease, and creatinine was 1.2, GFR 68. He's in great physical health. Generally speaking, I'm going to just say we would probably, I think everybody would agree, neoadjuvant therapy followed by cystectomy. Anyone? Yeah. So this patient got neoadjuvant dose-dense MVAC, followed by radical assisted prostatectomy, and there was residual T3N1 disease with 2 out of 12 pelvic nodes involved. A good reasonable tumor response seen on chemotherapy pathologically, but still with quite high risk disease. So Jeannie, Dan, Amy, any role for adjuvant systemic therapy here, and if so, what kind? Where's the future going with this? Little loaded, but.
You want to start, Jeannie?
Sure. So I think that this is a question that a lot of people ask because, clearly this is bad disease. This is a disease that, we worry about. There wasn't really a mention of the CAT scan ahead of time, but clinically the feeling is he had T2 disease. So this isn't uncommon that people will be upstaged, at the time of surgery, wind up having lymph nodes. If the patient got, an adequate number of cycles of dose-dense MVAC, then I think the tumor itself is telling us that, there's still live tumor at the end of that chemotherapy and surgery. So it's not clear to me that any more of that cisplatin-based chemotherapy would be helpful. So my answer to should they get more chemotherapy would be no. I don't think there's any data to support that. The current standard of care is that patients should get, follow-up imaging labs and scans about every 3 to 4 months for the first 2 years. We certainly worry more about this patient having recurrent disease, with those scans than someone who has a complete pathologic response. as far as I know right now in 2021, the standard of care remains observation, but there are, some interesting studies coming out, including the study of nivolumab versus standard of care, observation that looked like there was definitely a signal in terms of disease-free survival benefit. So I think that's of interest and something to be watched. There's several clinical trials still ongoing, so that study's maturing. There's a very similar study called the Ambassador study using pembrolizumab as the experimental comparator versus observation alone or standard of care. And there's also a selected trial using a novel FGFR3 inhibitor called infigratinib. That study is selected for patients whose tumors have an FGFR3 mutation or fusion. So I think there's definitely a lot of work in this space. We know that I think it's an unsatisfactory place to be in as a physician, to tell a patient that you're worried about them and then offer them a CAT scan and follow up. But I'm interested to hear what other people do in this situation.
So, Jeannie, my question on this is let's say that InVigor-010 never reported out no atezo benefit. Do you think that Checkmate 274 with such a strong disease-free survival would have been embraced more readily a couple of weeks ago when it was presented at GU ASCO?
Right. I mean, I think there's a lot going on in this space where one checkpoint trial, whatever the study space is, winds up being positive and another one is really underwhelming. So I think there's something about definitely the population. Is there something going on about the drugs that we don't completely yet understand, or any selection or not, in terms of, using a biomarker? But right, you have one randomized phase 3 trial that did not meet a primary endpoint, and then another one that looks, pretty impressive. I'm really not sure yet what to make of those data, but I think in this setting, survival is important because this is a drug that these patients would be getting at the time of progression. And so I think that because, they are not inert, and so I think probably more yet to come in terms of looking at that survival data to see really if there's an important signal here or not.
Great, that's makes sense. And then the question, institutionally speaking, the role of radiation in this setting. Holger, let's hear your comments, and then we'll see what they're doing at the other institutions.
Yeah, I think there is a role for radiation, although again, the data is sparse on this. There were 2 randomized trials that we look at. They are from Egypt, and they did show improvement in local control, but only kind of marginal improvement in disease-free survival and overall survival, so it was not quite significant. The problem, of course, in those trials, there was a high proportion of patients with invasive squamous cell carcinoma, which is more endemic in that region, and not so much the urothelial carcinoma that we see all the time. The NRG actually tried to answer this question on a larger scale. The NRG GU001 trial was launched, but unfortunately, they didn't really accrue enough patients. I think they closed after only 14 patients. So we don't know the answer, but generally it's tolerated relatively well, and I think it's something to consider. In a survey of radiation oncologists, even though the data is relatively sparse, a lot of radiation oncologists would actually consider using it.
So what goes on at Hopkins and at Vandy? What's the approach on that front?
I would say in general that these patients may or may not be discussed in tumor board, because we have 2 adjuvant trials, we tend to discuss the trials. Rarely, if patients have a significant positive margin, we'll have a discussion more about adjuvant radiation therapy in this space. As a standard, our patients will get a cystoscopy and an exam under anesthesia a few days before a cystectomy. So the rate of having a positive margin is pretty low because the surgeons are fairly, I think, sure of a resectable tumor before going into the operation. So I think the uptake of adjuvant radiotherapy is pretty low at our institution.
Yeah, I would say it's very similar here. If there is a positive margin, we discuss it and possibly go ahead and proceed with it, but it's pretty rare.
Okay, great. And some of that, it probably is a surgical approach too, because you're selecting out the patients on the front end, as Jeannie pointed out. Yeah. Okay, great. So this patient then is managed with interval follow-up, and at 3 years later, he develops metastatic disease to the liver and bone. His GFR is now 42, and biopsy confirms metastatic urothelial carcinoma. Question: would you give platinum-based chemotherapy? If so, which? What makes platinum candidate? How do you define platinum candidacy or not? And what are the alternatives under this situation? What's the optimal? Jeannie, what do you think?
Yeah, this is a lot of question. So I think the first part of the question is, do you consider like quote unquote retreatment with platinum-based chemotherapy? This is probably somebody who should be biopsied. 3 years is a long period of time between the neoadjuvant chemotherapy and surgery and the time to recurrence. So I think it would be important to get some new tissue. From a clinical trial definition standpoint, if someone has a disease-free interval of 12 months or more from frontline or perioperative platinum, then there should be a consideration for retreatment with platinum. So one way you can look at this is, well, they still had viable disease after neoadjuvant chemotherapy. Should we be thinking about platinum? The other way to think about it is, well, that was pretty locally advanced disease that was controlled for 3 years with platinum, potentially still sensitive. I think this is a challenging question, but reasonable definitely to consider a platinum-based treatment. What is the definition of eligibility for platinum? It's much more of a trial definition, but I think it can definitely be used in clinic as well. And then more recently with frontline checkpoint data, we had to also define what is completely chemotherapy ineligible. And so all these are consensus definitions. From a cisplatin eligibility standpoint, we think about things like comorbidities in terms of renal function. So in general, like creatinine clearance above 60 from a clinical trial perspective, but between 50 and 60 is usually reasonable for cisplatin-based treatment. Also thinking about functional status of 0 or 1, peripheral neuropathy, and issues with hearing, because cisplatin can lead to hearing problems. And then of course, any signs or symptoms of heart failure because of the amount of fluid we have to give. So if somebody falls into a category where they're chemotherapy eligible based on their functional status or renal function, but not eligible for cisplatin, we would use carboplatin in the first line setting, not in the perioperative setting, but in the first line setting. If something is completely ineligible to get chemotherapy, that may be somebody with a PS of 2 and a GFR less than 30, that may be a patient where you would consider not using chemo at all, potentially immunotherapy in the front line.
Great, perfect. So this, I'm gonna, in the interest of time, I'll move a little bit forward, but this patient got Gem-Cis followed by avelumab maintenance, stayed on it for 16 months, developed progressive disease. His molecular profiling showed MSI stable, FGFR negative, ERBB2 negative, we'll say BRCA2 negative, TMB 16, PDL1, TPS 5%. So what would the next line standard of care? This patient got platinum-based therapy, then progressed now on checkpoint inhibitor. What's your next management and why?
So for me, for this patient, I would consider the avelumab maintenance also as a line of therapy. And so they've had platinum-based chemotherapy, in fact, twice, and then avelumab. And so enfortumab vedotin has accelerated FDA approval in this space. And as I talked about in the talk, there was just a recent randomized phase 3 that was presented by Tom Pals at GU ASCO, showing a survival benefit over the kind of, at this point, pretty ancient comparator of single agent chemotherapy in that space. So in our practice, this patient would get enfortumab vedotin next.
Perfect. Heather, what enfortumab vedotin, what kind of side effects are you seeing with that, and how do you guys manage that?
So when I'm talking to my patients and teaching them prior to EV, typically they have a lot of side effects that we're used to managing in medical oncology: fatigue, peripheral neuropathy, hair loss, diarrhea, nausea, but there are some unique side effects that we want to make sure we're paying really close attention to. Most recently, the package insert was updated with a warning regarding the skin toxicities associated with EV. Typically, grade 1 or 2 rash managed with topical steroids or oral antihistamines, but there have been some cases of Stevens-Johnson syndrome and TEN even after the first cycle. So we need to be watching these patients really closely, and if the rash is not improving or there's any kind of mucosal involvement, we need to be stopping EV and getting them to a dermatologist pretty quickly. There can also be some ocular disorders, and so I usually just go ahead and start prophylaxing my patients with natural tears, and then if they have any progressive symptoms as far as that's concerned, they need to see an ophthalmologist before you do anything else like steroid eye drops or you know, something other than just natural tears. Excuse me. And then lastly, there is also hyperglycemia, kind of a unique side effect associated with EV, even in those patients who are not diabetics. So we're checking blood glucose prior to each dose of EV. And if the blood sugar is greater than 250, we've got to treat that, get that less than 250 prior to moving forward with the next dose.
Fantastic. So, thank you, everybody. In the interest of time, I'm just going to move on to the next case, and we'll do a couple highlights from prostate cancer. But the next case is a 63-year-old gentleman with Gleason 4+3=7 prostate cancer in 8 out of 12 cores. Initial PSA was 9. He then got a prostatectomy, T3N0 disease, with a positive margin. His PSA went to 0 for 3 years and then started rising, 0.12, 0.16, 0.26. So my question here is so talk about advanced imaging for a minute. And if you guys are doing advanced imaging right now, and if so, which, and how does that affect your therapy? We'll talk from Vandy and Hopkins, what they're doing.
So in this patient, we are doing advanced imaging, and we usually start with a CT bone scan. In this patient, I wouldn't be surprised if they both were negative. Given his trajectory, I would think this is more of a local recurrence, and I'd send him for radiation and probably wouldn't have done a PSMA or Axemin prior. But it is certainly something to consider in somebody.
Jeannie?
Yeah, it's probably a great question that somebody in our prostate group could be answering. But
Okay. That's okay. That's okay. Well, we can
but
ask.
I'll defer to your team.
Okay, Dan?
Yeah, I would agree with Amy. I think the role of advanced imaging at this PSA level, 0.2, 0.3 is pretty low. I mean, PET-Axemin definitely usually negative in this setting. PSMA sounds like the cutoff could be around 0.3, but here I think with the positive margin and with this other features, I think what we already know about risk stratification favors much more about doing adjuvant radiation. So I would not do advanced novel imaging in a patient like this. I recommend salvage radiation.
Holger?
Yeah, I would agree. The sensitivity for an Axemin scan in the less than 1 nanograms per milliliter range is about 34%. And then if we take a look at the very low risk, low PSA levels of 0.2 or so, the chances that we actually see something is very minimal. A lot of people still get bone scans and CT scans, and I think they're pretty much a waste of time, but insurance often mandate that if you wanted to get any other advanced imaging.
If you had PSMA availability, would you get it?
Well, again, it's you kind of right at the borderline in the lower area of detectability.
What's your number? 0.2, 0.3?
I think when you have a rising PSA over 0.3 PSMA, you might see a detection. But again, it's I think in patients where you have a real hint of where the biochemical recurrence is, like with a positive margin that looks like local, it's pretty easier to forego this. When you have patients that had clearly negative margins and no risk factor for increase for recurrence, then you kind of scratch your head and wonder if it could be in the lymph node as well as in the prostate bed. So I think, but the imaging really has helped, and we have actually seen nodal disease that we couldn't detect before.
Okay. Well, guys, this has been great. I would love to go through the rest of the cases, but I think I have to wrap up or I'm going to get cut off. And then, so what I'm going to do is I just want to thank you guys. Excellent discussion. I ask that everybody can log back on, and we can certainly answer any questions that have come up, or people can private message us in the lounge, and I'm sure any of us would answer. But we'll return to the, so everybody can, when we break, engage with the industry representatives, and I thank you all for your support. We return to the general session at 11:40, where you can choose between 2 different sessions, selecting a first-in-class oral therapy for patients with hormone receptor positive HER2 negative metastatic breast cancer, presented by Dr. Virginia Kaklamani, or LonSurf, oral chemotherapy for previously treated metastatic colorectal, gastric, and gastroesophageal cancers, presented by Dr. Michael Morse. Both really awesome learning opportunities, and you'll receive a gift card if you attend.